Okay, so good afternoon, everyone. I'm Shambhavi from Yod, and I'm welcoming you all today to this expert session. Uh, the session is What's the Vibe? Understanding the digital health scenario for youth in India. I'll briefly introduce you to the session so you know what it's gonna be like. This session shares the research insights and current digital health trends among youth people, emphasizing their online behavior, perception, with a key focus on data governance and digital privacy. Through multiple segments and thematic discussions with panels, the facilitation will be discussing the research insights. It will allow participants to co-learn how digital culture influences health behaviors and inform practices as we imagine sustainable digital health future for innovation and implementation. The interactive format is aimed to encourage active participation, providing a platform for exchanging ideas that can form digital health outcomes in India with a focus on young people. I would like to call upon the stage our panelists for today. Nirmala Nair, founder and director, Kaboom Social Impact. Dr. Dimple Bhargav, officer, Digital Health, Wish Foundation, India. Dr. Ayesha Bashir, communication manager at Asia Safe Abortion Partnership. And Shivam Shamsher.
Hi everyone, welcome to this session and thanks for choosing this one. I think there were too many options. I was even getting puzzled like how this whole session is, planned. So this session is essentially about, I need to take, okay. Yeah, so this session is all about communicating digital health. Given that we are having a lot of technical sessions on digital health, I believe there's a session on AI and around marketing and so many things which all the young people here are working on. So this session is about how do we communicate with young people around digital health concerns because I mean all of you are experts here in some way and digital health can be a misnomer for common people because anything to do with health and technology becomes digital health, right? So how do we communicate this with young people? So we will be presenting research which we did at Kaboom. So Kaboom did a research for Transform Health India Coalition in assessing what are the social norms and practices around digital health. So let's dive deeper into this research. But before we go there, let me invite Nirmala Nair, the founder at Kaboom, who will be talking to you about what Kaboom is and why we did this research. So over to Nirmala.
So I can't stand behind a podium because I'm vertically challenged and then you can't see me when I do this. Can you hear me? Yes. Okay. So I guess I probably am the only one here who is not a digital health expert. I have really very little to do with the health sector or the digital health space. But what I am an expert is how to communicate all the expertise that all of you have to common people who don't understand all these big words that everybody seems to be using, right? We saw the sessions in the morning. And there was such interesting insights that I heard. I mean, I learned a lot because I know very little about it. But I kept thinking that the audience that I talk to, how much of this do they even understand? And therefore, what we want to do with this session is, because it's, again, a communication-led session, you don't have to be silent. Whenever you have a question, you can raise your hand and we can go ahead and sort of, take that question. There is nothing sacrosanct. So about me, I am a founder of a social impact agency called Kaboom. Kaboom works on building user-centered or people-centered narratives and products to ensure that whatever the communication may be about whatever issue, we're able to reach people in a way that they understand it and they can consume it and they can use the products that we create for them very, very easily. And about the research today, this research was done along with Wish Foundation as a part of the Transform Health India Rajasthan Coalition, and it was supported by Transform Health. And to start this session, I want to ask you some of the basic questions that we asked internally when we started this research. Because, like I said, we're not digital health people, right? So when this came to us, for us, there was a lot of new things here. So the first question we asked was, what is digital health data? And I ask you the same question, and you will understand why I'm asking you this, because when you see the research and the results, you will see where I'm coming from. So what is digital health data according to you guys? You folks, sorry. Anyone? Yes?
Digital health data is something to do with your health record, your, your well-being, and it is regulated and controlled by the ministry relevant. It's something to do with your, you have an Aadhaar card which keeps building up, and then you have some sort of a data which gets encrypted on your card or something of that sort. And the doctors can protect your privacy as well and provide you with treatment as and when required, depending upon the ailment that you have. But nowadays, more and more people are talking about, instead of going to the hospitals, why not go to the wellness centers? Because prevention is better than cure. So digital data is all about that. That is my understanding about it.
Thank you. And that's exactly where we started. But then if I go to Apollo Pharmacy and if they take my number and they have details of my prescription, is that digital health data? It is. Oh, and if I were to go to a website and they ask me to log in and I sort of search something there, is that digital health data? It is, right? And that's what we learned, that it is. The definition of digital health data is very, very wide. And all of us can keep adding things that would sort of incorporate what digital health data is. Do we know where all our digital health data lies? All over, right? It's all over India.
Because right now it is in the formative stages.
Yes.
And as and when it develops, the digital health data will be accessible to because all the entire population of the country needs to be under this umbrella government.
Yes.
And that is how it will be evolving as a process of evolution.
Yes, exactly. And do we have access to our digital health data right now? In the morning, we had Anaita and Akash talk about, how it is being planned that we will have access to our digital data. But we know that it's some time away for all of this data that is all over the place to kind of come together. And therefore, we think this is a great time to have this conversation. Because we're starting out that process. We're not a country which has reached there where everything's done. We're a country which is building it. And therefore, it is important to have a narrative where we know how to communicate this to people, to common people. If Lalita doesn't know she is pregnant, but she is a data point, as was mentioned in the morning, similarly, if you ask somebody for their data and they say, OTP aayega to mera paisa le loge, the answer is not that trust me and still give me your data. The answer is to figure out how am I going to protect that data. Am I taking data that I am protecting? Am I taking data that I am safely handing over to them, right? And that was the perspective of the research we were doing, right? And this is the big question. Should we have access to our own digital health data? Of course, right? Of course. Yet we don't right now. And we, sitting here in Delhi, working in the digital health sector, are saying this. So think about a common person out there, right? This research was basically done to figure out how can we do a public campaign to reach out to young people to shift the narrative around digital health and simplify it for them and ensure that they are empowered not just in understanding digital health, but also data health governance, also digital privacy, and all of this together. And that was the purpose of this research. The research was again, about perceptions and behaviors. And Shivam will take you through the research process. This may be a little sort of, it's just one of those essential steps where we have to tell you what the research process was, right? I'll tell you this was a qualitative research. It was a research led by human-centered design methodology. It was not a formative research. So we weren't looking at large numbers. We were looking at smaller numbers, but trying to get enough and more details from there. Yeah, over to Shivam. And if you have questions, just go ahead and ask.
Yeah, can I have that?
Sorry. Yes.
So I just wanted to ask you this, that preliminarily, did you even ask this question that in the current format, physical records are also present everywhere, right? And physical files and all of our data is available with us and also with the hospitals that we are working with. So the entire concept of privacy, security is still under, it's a concern still. So, I mean, just to start that conversation there, that because we just jumped down to the digital health data, but right now our data in the physical form is available everywhere and anywhere.
Yes, true. But it's a physical form and we know how much it can travel. Unless someone wants my data per se, you see. But having said that, I'm not saying that allows for it to not be private. No, we did not delve into it. We did not delve into it because what we also figured, and you will see that, we also figured is privacy itself is an idea which is alien.
Yeah.
Right.
Data, physical, whatever. Privacy is an alien concept. We're not a society that thinks about privacy. We are people who go around giving our data everywhere. Look at the amount of data you collected outside there while registering. Did one person say, I will not give it?
Yeah, so that's why that's
Exactly.
implicit consent.
One person did. I did. I said I'll not give it. But that's what I'm saying. I did this research and now I'm informed. So that's my point. See, the important thing to realize is that we're not thinking in that space only. So unless we give people fodder to think in that zone, they're never going to think in that zone. And we don't focus on things like that. We're so busy making chatbots and apps, I mean, I'm not saying that's not necessary, it is, but it's important to think about this also parallelly, not as an afterthought.
Yeah.
Yes, and this may actually give
Yeah.
you some ideas.
We can take this in the discussion session. Maybe we can just get a brief of what this research was about. I think many of you are interested what we actually did. So as Nirmala was pointing that this was a research which we were using to design a campaign per se, and our focus was on having these insights. Not something which is very quantitative in nature, but which is something which will work with young people. That's why we call it what's the vibe, right? What's with young people, what they actually think about digital health and what their understanding about digital health is. And these questions which we are thinking right now in terms of data privacy, data governance, right? These are sector experts, maybe we might have certain understanding, but it might not be a everyday reality for a young person per se, right? When we think about it, because digital is everywhere now, even in the health space, and people necessarily don't think about it within the health space. It's, I think, us who are thinking about it, and that's a good thing. With that, these were some of the research questions. We were looking at doing a profiling of the young people in terms of understanding the socio-economic factors, what dictate young people to be online, what are the motivations for which they are online, and what kind of health information are they seeking online. And further, we were looking at what are the new set of challenges which are emerging. As we are seeing digital as an opportunity, as innovation, right, there are new risks and concerns which we are discussing here in terms of privacy, data governance, and other things. So how did we go about it? So we used a mixed method approach in doing so. And human-centered design was something which we kept at our was something which we based our whole research on. We made use of key informant interviews with stakeholders. We did FGDs with young people. These FGDs were essentially in Rajasthan because we were thinking to do this campaign in Rajasthan. And we also did a CAP survey, a knowledge, attitude, and practice survey across India in several states. I can take you more through all of this. So if you look at the key informant interviews, we have a range of key informants because we believe as you all of you are here experts in this space, and this area might have certain expertise, which needs to be communicated with young people. So we were also trying to see what's the gap, how sector people, how technical people are looking at it and how it operates on field. So we were looking at various stakeholders. It included program implementers, designers, data experts. Even we looked at certain journalists, how they are reporting on it, because for us, narrative was very important because we are thinking of communicating it at the scale, right? So all of these stakeholders become important. And in terms of CAP survey, we did a CAP survey with 543 participants. We were since our focus was very gendered, you can see like 60% of our participants were women and 40% were male, and there were a few who didn't want to identify or wanted to be recognized as others. And this is the state-wise distribution. You can get into the report to see the technical details. And these are some of the pictures for CAP survey. So we did this using an online form, as well as we asked data enumerators to go on field and do this. Since we were also targeting hard to reach geographies, we also realized that perhaps digital might not be the right way, but there are ways people access this, because mobile ownership in rural spaces might be a constraint. So maybe using a physical approach might be helpful in that direction. And these were certain focus group discussions. So we divided this into 4 stakeholder groups. As you can see, these included young women between 18 to 24, women between 25 to 35, young men, and young LGBTQ people. We also thought since data privacy and other concerns are especially heightened for vulnerable identities, it might be important to get their perspectives as well in this direction. These are some pictures of a FGD, what we were talking about, the FGD in terms of using design tools to, gain insights. So let's look at some of the research insights. So before going there, we thought it might be good for a communication agency to actually understand the larger landscape around digital health, right? So we did a big picture. We were looking at 3 factors, which included government, market, and communities. Our data is essentially, the primary data here is the community perspectives. The community here represents the young people community. And let's dive into what the government and the market perspectives are looking at. So all of you know about Ayushman Bharat. I don't need to get into that space in terms of what is happening, the new ID schemes, Abha schemes, and everything which is happening. And a huge base is around the fintech sector, which is an exemplar within the global landscape, how India has been able to adopt all of it, and how we are replicating a similar modality within the health space as well. So that becomes a background for digital health work as well, when we are thinking of federated architecture in terms of sharing different kinds of data with different stakeholders, be it pharmacies, be it doctors, or even people have their own access to this kind of data. So federated architecture becomes important within health space, but this is something which also remains very technical and not something which is commonly understood, right? Then we also realized that there were certain cybersecurity and data breach concerns, which we can see with our vaccination data getting leaked, and a lot of cybersecurity attacks, which various government hospitals have even faced recently. Like in 2023, AIMS had a cybersecurity attack. I think yesterday's Microsoft attack could also be a good example of how maybe some hospitals were also impacted in that direction. So in terms of market perspectives, we were looking at what are some of the big tech, how they are investing in this space. So we see certain examples of Google, Amazon, Microsoft, also partnering with various organizations. And then this becomes a matter of scale, because then they are able to reach, right? And then we looked at examining youth-centric digital health applications. So our focus was to look at certain chatbots, right? Chatbots are everywhere. So we tried to review certain chatbots. Some of them are here. These are essentially sexual and reproductive health-related chatbots. And these are also implemented by certain development agencies, right? So we also see that there are certain concerns within these chatbots, though they are made with a lot of thought, behind reaching the end users in that sense. And in terms of market regulation, I think there's already a policy which we have in terms of a blueprint, in terms of certain features around interoperability, privacy, and other things. So that's essentially about the big picture. And for the digital behaviors of young people, I think Nirmala would be the right person to talk more.
So, in terms of the insights that we got as we sort of went along analyzing the data that we had, the very first one, as you can see, we called it Hardin Digital because we were. So one of the conditions we had was that we were doing all the FGDs with young people who had their own phone, so they had personal phones, right? So that we know, so that we're analyzing the behavior of somebody who has a phone and not somebody who's not on the phone at all. And these were all. While we did it in Jaipur, in and around Jaipur, they were all people who were from outside Jaipur. They were all from really small towns and villages in Rajasthan, all the young people that we were talking to. So the very first exercise we did with them was really ask them how much time do you spend on your phone, And we got answers like 5 hours and 6 hours and things like that. And then we did an activity with them, which you can see here, which is we broke their day into 4 parts and asked them to write down what you do on your phone in these 4 times of the day. And people realized that they spend 16 hours and 18 hours on their phone. And if you do that exercise, you'll also realize that you spend a lot more time on your phone than you actually think you do. And it was very interesting. So phone is the first point of contact for young people now. Phone usage has disrupted sleep. Doom scrolling is real. It is dooming their lives. Instagram has what started off as beauty and all of that has become the go-to for everything. Even news is consumed on Instagram now. And digital payments. I mean, young people are far more savvy with digital payments than the older people, especially in Rajasthan, because we've done this for something else in Rajasthan, where we know that older people in Rajasthan are far more wary of because of all the scams that have happened to them. So you can see here what they spend their time on. So the first 71% of their time goes on social media, then on Google search, then on streaming, shopping, online banking, dating apps, gaming, and something that they didn't want to talk about. So, so the next point was really, where are young people consuming their health information from? And this is what is very interesting. 70% of that health information is being consumed from YouTube. If I have a health concern, if I have an issue, I go to YouTube and I check. Then I go to Instagram. I go to groups on Instagram, which give me that information. Then there is WhatsApp. And then there is Facebook. Facebook's not dead. 36% of young people are still going on Facebook. So you can actually see that what they've said is, if I read the quote, it says, online platform एक easy process है जिसे आसानी से देखा जा सकता है. For anything else, if I have to download an app and all that, that's a cumbersome process for me. And therefore, unless there is somebody coming and making me do it, I'm not going to do it. I'm not going to do it by myself, right? The next interesting part, what we found was that, while online and digital health is very sort of common for young people to use, we have to also understand that digital health is designed to be individual, right? It is designed as an individual using an individual platform to get an individual's result. We're not a society like that. As a society, if we're unwell, we don't handle it by ourselves, do we? And, so we don't. We're not used to that. We're used to telling people when we're unwell, right? And what is happening is there is a contradiction that we're facing there. You'll see there's a very interesting quote by Dr. Subhash Ghosh, who talks about how the use of digital health is alienating people because they're not used to it. They still want to do this in a community manner. They still want to be social. They still want their family to be involved. But if I get into one-to-one care, I don't have that familiar sort of environment that I'm so used to. And we're not thinking about that. We're not trying to include our families into our digital health process, whereas we don't live like that, right? हम तो डॉक्टर के पास भी अकेले नहीं जाते, हमारे साथ कोई जाता है ना. It's a very standard thing. That's how our society works. And we're trying to do something that is not natural for us. Right? Now, language and understanding. There's so much conversation around this. In the morning also, I heard Anaida and Akash talk about it. There's such complex words, such complex terms when we're going through all these apps and chatbots. Itni badi badi baatein keh rahe hain hum log. When you ask a young person, what is health data? What do you think they say? I want you to guess what the answers we got were. Like just randomly guess. What did you say? Weight. Okay. COVID vaccination. So one of the things that we were getting from these young people, and these are, trust me, these are 18 to 24-year-olds. We're not talking about old people at all. The first question they said, health data ki data? So we said, data kya hai? So we said, data mobile recharge hai. Health, health hai. Health data कुछ नहीं होता. Health records होते हैं. ठीक है? Health records होते हैं. Data mobile recharge करने के लिए होता है. और health data कुछ नहीं होता. मेरा कोई health data नहीं है. That's the most common answer that you get. Right? So while in Delhi, we sit in IIC and do these conferences on digital health data, a common person has no idea what it means. And young people, not old people, not uneducated people. These are people with access to not just mobile phone, but smartphones, right? Yeah. So data, and this is true for most of India, right? Data का मतलब ही कुछ और होता है भाई. Then there is, there is this understanding in English, right? For young people. There's a lot of understanding which is English. It's not English, it's not Hindi, because I'm talking about the northern belt. I'm not even talking about the southern belt here. So a lot of conversation in English. But many of these digital terms don't have any direct translations. And हमें भी नहीं पता उसका मतलब क्या होता है. My English is very good. लेकिन मुझे नहीं पता उसका मतलब क्या होता है. They are health terms. And we throw these terms at people. They have no clue what it means, which is why Lalita doesn't know she's pregnant, because she's probably seen that app, but she doesn't know uska matlab kya hai. And if she asks someone ki iska matlab kya hai, she never gets the answer. Right? We don't train ourselves to give that answer. We don't give anyone that answer. क्योंकि कितने लोगों को देंगे answer? अगर physically answer देने लगे तो कितने लोगों को देंगे? I'm not blaming the person who's not giving the answer at all. Completely understand their predicament. How many people are we going to answer? And therefore, these things need to be inbuilt in the design of the products we create. Not as a brochure and a communication that happens later, and not as a case study that happens later. We need to think about this while we are creating our stuff and not after that. This is as important as all other research and data we do. So with that, I'm going to stop here, and then we're going to go over to Shivam now.
Great. Thanks so much, Nirmala, for that. I think it gives a good overview of, what we are talking about and what this looks like and what was the language and what we were essentially doing at, right? So now let's look at some of the research themes which we have discussed. For doing so, I would like to call my other panel members. So we also have a doctor on our panel, Dr. Dimple Bhargava from Wish Foundation. I would like to invite her. And we have Aisha Bashir. She's the communication campaigner at Asia Safe Abortion Partnership Alliance, ASAP. I would request Dr. Dimple to please introduce herself and her work at Wish Foundation, and also Aisha.
Am I audible? All right. Thank you so much for the kind introduction and inviting me and having me here. So I am Dr. Dimple Bhargava. I am working in the Wish Foundation as an officer digital health. So I primarily work in implementing and making all the products. For example, recently we have made one platform which is open source, now in public domain, named eSwasthadham. So making all the products related and relevant to digital health and then implementing them on ground, enabling with ABDM and all the ABHA components is our key domain right now. And making people aware and more educate about all the components and importance of ABDM, ABHA, data privacy and security, and making them as comfortable as we could is our primary object, so that we as a nation and India in healthcare domain will proceed and, touch the sky in every way possible. So that's all. Thank you.
Hello, yeah, this is good. So yeah, my name is Aisha Bashir. Thank you so much for, again, as Shivam said, choosing to be here, to be in this space. For me, this is actually a very great opportunity. Actually, I was discussing with Nirmala as well that, I actually work on abortion. And we work on abortion across Asia. So, raising awareness around abortion, talking about access, how you can increase access. So for us, we didn't really ever think that we are also technically working on digital health, because exactly of what you said, that what does digital health mean really, right? And it's very broad. So it was for me to kind of see very interesting to kind of collaborate and come together. So thank you to Kaboom for this opportunity and for creating this space, because so for myself, so I work, as I said, with Asia Safe Abortion Partnership as the communications and network manager. I have been working on the abortion space for the past 6-7 years. Before that, I was working for a few years on SRHR space, which is sexual health and reproductive rights. And over there also, it is all again very focused on health, because we were working with gynecologists in Delhi to kind of increase access to SRHR services for unmarried women. Because if anyone who is here in Delhi and has visited being unmarried gynecologist, and when they're talking about your sexual history, and they always ask, are you married or unmarried, instead of are you sexually active or not active. Before that I was working on that space, where we were kind of working with gynecologists to kind of create a safe space for the patients that are there. So for me, this is very important that, because as you, in your research, it kind of came out that लोगों ने बोला कि easy है online जाके information, gather करना. But also because maybe the doctors or the healthcare system in the physical space is not providing that kind of a safe space, or not providing answers. And especially when you talk about, again, in my field in SRHR, and again, even abortion, that is something even more, something that not willing to discuss with anyone. So abortion के लिए तो आप online ही जाओगे. आपके पास option नहीं, especially अगर आप unmarried हो. So yeah, so this was an interesting kind of for me to also think about, and exciting to see, the conversation that we have today.
Great. So with this, the first theme we are discussing is about digital is global, right? We are discussing concepts about digital citizenship and, which is very global in nature in terms of what we are looking at. So we asked our young people, how much their health data matters to them, right? If a control to the health data matters to them or not. And you can see that 85% said that it's very important to them, right? But we also see that those behaviors are not that way in terms of how they report, right? It's something which they believe that it's important to them, but it's not essentially replicated. And then my question for my panel is basically, especially in terms of universal health coverage, when we are talking about, because then digital platforms are essential, that's what a lot of governments are reporting, that because of digital platforms, we have been able to achieve UHC. And so my question is, with UHC, what kind of data privacy concerns you are observing, especially because like a country like India, where young people contribute such a significant proportion when we think about UHC. So how can we rethink about data privacy concerns in that space? So that's one, yeah.
Yeah, so in terms of UHC, it says that we are going digital for all and digital health for all. And UHC can be achieved in that matter also if we expand all the possibilities of being digital in a very safe manner. So first of all, it is very important to understand the root cause, the gap, the analysis. as Nirmala rightly said, that we are talking about big things, product, implementation and whatnot, but we are not at all understanding the fact that the common people who are not at all digital experts do not know what is digital health, what is data, what is health data. So first of all, let's start with the start. India is a very emotional country, people consisting of very emotional aspect and all that emotional IQ. So we as a Indian believe that जब तक डॉक्टर हमसे आधे घंटे बात नहीं कर लेंगे, 3 बार हमारी नब्ज नहीं चेक कर लेंगे, हमें अच्छा लगेगा ही नहीं. So what is teleconsultation? आई मीन मैं स्क्रीन पे एक डॉक्टर आए और मैंने फीस भी दिया एंड देन ही वेंट. ओ माय गॉड, मेरा मनी वेस्ट हो गया, डॉक्टर ने मुझको टच नहीं किया एंड मुझसे आधे घंटे बात नहीं करी. सो दिस इज़ नॉट हैपनिंग फॉर मी. सो वो साइकोलॉजी सेट है कि डॉक्टर के पास जाना है, डॉक्टर को हमें बिल्कुल प्यार से कंसोल करना है एंड आप ठीक हो जाएंगी चाहे उन्हें कुछ भी हो. सो दिस इज़ द कॉन्सेप्ट दैट वी फॉलो. सो keeping this in mind, we should practice B2B2C instead of B2C because एक middle man का होना बहुत ज़रूरी है. For example, अगर public health domain की हम बात करते हैं तो there are tabs and mobiles and n number of applications जो कि हम आशा वर्कर्स को दे रहे हैं. हमने उनको एडुकेट कराया कि दीज आर दी एप्लीकेशंस मैम एंड ये आपको हम टैब्स प्रोवाइड कर रहे हैं जिसको आपको गांव-गांव जाकर सारी प्रेग्नेंट लेडीज़ का डेटा कैप्चर करना है. नाउ इट इज़ B2B2C. द मिडल मैन इज़ आशा जो कि ऑलरेडी बहुत कंफर्टेबल है उस प्रेग्नेंट वुमेन के साथ जो उन डिफरेंट विलेजेस में हैं. तो वो जाती हैं, उनको यकीन दिलाती हैं कि यू आर सेफ, I am safe, okay, with you, and you can tell me everything about yourself, your data, your pregnancy का time, your still live births, etc., etc., and comfortably pregnant woman वो चीज़ उसको बता देती है. Whereas ये चीज़ B2C होती कि directly एक lady को अपना पूरा data digitally feed करना है किसी system पे, तो उसको काफ़ी hesitation होता कि oh my God, कैसे ये डेटा मैं डाल दूँ, इज़ इट सेफ और नॉट, पता नहीं कितने लोग इसको व्यू करेंगे, कहाँ कहाँ ये रिपोर्ट फॉरवर्ड होगी. सो इन दैट मैनर अगर हम लोग B2B2C प्रैक्टिस करते हैं एंड हमारी डेटा प्राइवेसी की पॉलिसीज़ को थोड़ा और रीस्ट्रक्चर करके एंड इन्वेंट करके ये सारे टर्म्स को इनकॉर्पोरेट करते हैं, देन देयर इज़ अ पॉसिबिलिटी दैट वी कैन रीच द हायर माइलस्टोन्स ऑफ UHC in terms of digital health privacy as well.
So you mean like to have a mediator in place or to directly report it?
मिडिल पर्सन सो
okay.
दैट बिकॉज वन स्टेप एट अ टाइम ना, सीधे लाके बहुत बड़ा टेक्नोलॉजी किसी के सर पर डाल देना बहुत प्रॉब्लम हो जाता है. लाइक आवर पेरेंट्स, UPI जब आया तो काफ़ी बार उन्हें हमें समझाना पड़ा कि डैड इट इज़ सेफ, इफ़ यू पे थ्रू गूगल पे और फ़ोन पे इट इज़ सेफ, आपके अकाउंट के सारे पैसे नहीं जाएंगे, उतने ही जाएंगे जितना आप टाइप करेंगे, OTP आपको ध्यान से देना है. ये सारा एजुकेशन हम भी मिडिल मैन बन के अपने पेरेंट्स को या ग्रैंड पेरेंट्स को समझाते हैं सो दैट वो कंफर्टेबल फील करते हैं, देन प्रैक्टिस कर पा रहे हैं. नाउ दे आर एक्सपर्ट्स. नाउ आराम से पेरेंट्स हर मंथ अपने बच्चों को पेमेंट कर देते हैं गूगल पे एंड फ़ोन पे से. तो इट इज़ लाइक दैट द अप्रोच शुड बी वेरी अंडरस्टैंडेबल एंड कंफर्टिंग सो दैट एक ट्रस्ट बिल्ड हो, एक बॉन्ड मेंटेन हो एंड इंडिया एंड द कॉमन पीपल उसको अडाप्ट करके आगे बढ़ पाएँ वे फॉरवर्ड.
Great. I think that might work for certain issues, of course. But I also wanted to ask this question, when we are working on restrictive issues like abortion or, say STIs or pregnancies or SRHR, right? It becomes a space where we essentially don't want to go and have a mediator in that space, right? We want to go and talk directly to a healthcare provider. So I think, Aisha, in your work, right, how do you see privacy as a, major component?
Absolutely. I think privacy is the key. Also, with regards to what, again, going back to what Nirmala had earlier said, that privacy as a concept is something that we need to understand. Here, privacy is seen as something that you need privacy means you have done something wrong. So that's how we see privacy even today. And especially as Shivam said, in terms of, for SRHR, these are very personal issues that people have, especially with women, because we don't talk about, there is unfortunately not enough comprehensive sex education. Conversations around something as basic as menstruation is now sort of it has started coming up where we are openly talking about it. But abortion is still, I feel, it has a long way to go where people can trust anyone with the information. On that, I would actually like to say, unfortunately for us, being working in the sector and managing the communications and looking at the online communications, for us, social media unfortunately has been a very important part of it because that is what people are using. Because so we mainly don't even work in India that much. We work in countries like Philippines. We work in countries like Sri Lanka, where abortion is absolutely restricted. Like you cannot. And now in the US also, with what we are seeing, and in US we have seen how through social media conversations, through people who want abortion have reached out to doctors. Those chats have been shared by Facebook itself. Whenever the government has kind of asked for, the state government in the US has asked for it, wherever the abortion laws are very restrictive. So data privacy is very, very integral to our work, I feel. And the sad thing again is that cyber security again एक ऐसी terminology है जो सुन के लोग डर जाते हैं, data safety, cyber security, आप ये क्या बात कर रहे हो? This is not for an individual or us or anyone working like, in an NGO sector. It is maybe for someone who is, directly targeting the government, जो कोई whistleblower type है, तो उसको ज़रूरत पड़ेगी. But that's not the case. So what we have been doing with our organization, ASAP, is that we have started this campaign, shaping safer online spaces for abortion rights advocates. We did actually a survey where it was a global survey. We had respondents from across 23 countries. Almost 40 of them were organizations who were working on abortion and sharing SRHR information on social media. The other rest were like individuals who were passionate advocates who share information. And almost all of them said 2-3 things definitely came out. One was that they face a lot of censorship from social media platforms directly. So even as part of our work, we feel that whenever we are doing and uploading a post, for example, और उसमें गलती से अगर abortion word है, या सेक्स वर्ड है या सेक्स एजुकेशन वर्ड है, तो उसको अपने आप वो शैडो बैन कर देंगे या उसको रिमूव कर देंगे पोस्ट को. While at the same time we have seen trends like, I don't know if you follow this Instagram influencer Dan Bilzerian. He's a very problematic guy and he posts half naked pictures of women around him, and that is absolutely, it stays up on Instagram. Uski community guidelines ko unko koi problem nahi hoti hai. But when we talk about abortion, they take it down saying you are promoting self harm. So that is what the dynamics are, the power dynamics are that we are dealing with. So it was becoming very, very difficult for us to, continue sharing our information, continue reaching out to people who might, who might be in, because also abortion is something that is like a do or die situation. You are not going to, अगर आप information बंद कर दोगे share करना, जैसे बीच में हमने अभी, we did a campaign on talking about self-managing abortion, and because pills, there are pills that you can use to self-manage an abortion as well. And in countries where abortion is, is liberal, it is very much allowed. In fact, in India, if you look at the data, in the past few years, 70% of the abortions that are done are through pills, are through medical abortions, right? But when we started sharing this information on our social media, we got massive trolling. We got taken down from Facebook saying that, again, what are you doing? Women are going to keep popping pills and kill themselves. But that's not going to stop them. If they need an abortion, they will get it through an then a unsafe way, which is going to risk their lives. But they're going to get it. What we are doing is we are providing information online that is WHO approved for them to access and understand and self-manage the abortion themselves. Exactly what you were also saying, that they this understanding कि doctor हमें देखेगा नहीं जब तक, that whole thing. So we are also kind of saying that it is something that you can do up until this many weeks. You can also do a self-managed abortion. So when we were talking about it, again, it got taken down. All of that information got taken down. So these are the challenges that we are constantly also fighting online and on social media. But yeah, I think it's a long way to go for us. We are now starting to understand how important cybersecurity for abortion rights advocates is, because I feel that when we talk about abortion, when you are giving someone free access to information on how they can manage an abortion, you are giving them sexual freedom. And when you're giving them sexual freedom, that is challenging a lot of patriarchal values and foundations that are otherwise normalized. So I feel that it's extremely, important for us, more importantly, because we are also facing opposition. आप हर religious group साथ में आ जाएगा abortion को oppose करने के लिए. वैसे वो आपस में उनकी ना बनती हो. Oh, there's a question. Yeah,
Yeah.
please go ahead. Very interesting. Abs- Absolutely. I have two things to say to that. Firstly, I completely agree. I feel India, compared to a lot of other countries in Asia, has a very liberal and a good abortion law, you would say. But the interesting thing is that people have no idea about it. The lack of awareness. And that is the thing with everything, cyber security, data safety, lack of awareness is the thing, right? While on the other hand, for something like a Beti Bachao, Beti Padhao campaign, the government has spent a lot of money on its marketing. You would see posters, campaigns everywhere. So लोगों को अभी लगने लगा है कि abortion ही illegal है. So we have, we actually did a survey like randomly, I think in CP we had done, and we asked people, and predominantly all of them said that abortion illegal है India में. तो लोगों को तो पहली बात तो ये awareness वो है. The other thing is for us to get involved into legal, this thing is a bit challenging because NGOs don't have that kind of resources. So we are fighting a lot, putting down a lot of fires at the same time. So for us to, तो हमारा क्या होगा कि अच्छा online अगर trolling चल रही है, कुछ चल रही है, another tactic that we have used is that we have a large network of medical students and doctors. So we asked our medical students and doctors to come online and respond to these questions and say that you as a doctor verify that what we are sharing is verified information, is WHO approved and all. So I think these are different tactics. The legal aspect is definitely there, and I'm sure like with organizations that have a lot of money and funding, I'm sure that is one approach that they're taking. So yeah.
Yeah.
Absolutely, I completely agree. We in fact have a youth kind of a medical student collective here in India also. So maybe you and I can get in touch later and we can put them in touch. It's called India Safe Abortion Youth Advocates. They're based in Bombay, and they are a collective of medical students who are pro-choice and working on abortion awareness. So, and we do work a lot with medical doctors and students for choice also. So maybe we can connect and do something together. I completely agree because a lot of information is coming from the West, and that we're not really aware of the Asian legal standards and what are the limitations that are there.
Hello. Yeah. Okay. So I'm going to step in and say that the with all my love for SRH, the moment we start talking SRH, it's only SRH. I do a lot of work on menstruation, and I keep saying that the moment you start talking SRH, everyone forgets their periods. It's so easy. But I think to come back to the point where we were is. It's important to make the difference between essential services and all other services. You see, essential services are, in that sense, fairly easier to deal with, right? Polio ke drops or vaccinations, these are imperative. We all know that. There are areas where there may be judgments, but there are not large patriarchal systems, large religious bodies playing against them. But when it comes to issues like abortion, when it comes to other SRH issues, when it comes to people who don't want to reveal their identity, you see, that is where all of this stigma, all of this privacy becomes way, way more important. Yes.
Hi. So I would agree with her in a limited way, as the moderator also said, that for SRH, for mental health, it's actually the exact opposite. You don't want a middleman, right? And just from my personal experience, I have talked to a bot and talked some very deep personal issues and fears and anxieties. And I haven't I also went to human therapists, right? Uh, I haven't experienced the same level of empathy. And I'm a computer scientist by training. So these, we don't fully understand why they are empathetic, but there's a research effort by Google called MedGemini, right? And they did what they did. Just to briefly summarize, they evaluated the response to the AMIE chatbot by by human patients, and also like response received by Amy, the chatbot, and response when you go to a physical PCP, primary care physician. And on all 6 axes, including empathy, the chatbot performed better. Now, you could argue that the daily clinical workflow is not, doctors don't type responses in a chatbot window, but we should not discount the fact that AI and empathetic AI will play a big role in SRH, mental health, and a bunch of other areas.
Absolutely agree to that,
Yeah.
actually. Right?
Definitely, I think we need a more responsible approach to technology and healthcare, which we are looking at, and that's why our concern is around, discussing issues around privacy, data governance, which might also impact. And the next theme which we are discussing is around digital glass ceiling. I think a lot of what we just discussed right now was also covered previously, but I think there's this interesting quote in our research which we found. Just a second. Yeah. So we had a political activist. She talks about if a woman is working, educated, or also married, then having her mobile phone is seen as okay. However, when it comes to her phone for health issues, she is looked down upon as she has done something wrong, as what all of you has also pointed, and she's seeking something, which she should not be going online for. So we see like how these essential gender norms, restrictive gender norms, are also replicated in online spaces, which further restrict women to go and access healthcare online, right? So this is also seen in this case. If my periods are not on time and I go to the doctor asks me a lot of questions and presumes like what wrong have I done, right? So there is a double judgment which a person is facing in terms of the gender, the health system, and everything, right? And this is then also replicated online, and with a new layer of privacy protection, and I have to restrict my identity and not show too much when I'm going online. So how do you feel about it, as also women who are going online?
I want to start with the anecdote of, what happened when we were doing this. And it was very interesting. There was one girl there who was 2021. And she handed me her phone and she said कि मेरे phone में सब कुछ है, Instagram भी है, TikTok, whatever, जो भी था, मतलब उसने 3-4 apps बोले, उसने कहा आप ढूंढ के दिखा दो मुझे. And I couldn't find anything. And I was mighty impressed. I said, oh my God, like, these girls are so good and they know how to hide their apps and stuff like that. And I said, I've never done anything like that. And I don't know any of these things. I'm not technologically advanced enough. But there was a colleague of mine sitting next to me who said, Nirmala, do you realize the privilege that you've never had to hide an app? You see, and that's what gets you thinking, that I have so much privilege that I've never had to hide anything on my phone because no one checks my phone. You see, no one judges me based on what is on my phone. And that is not the reality of girls and women in India. And that's the unfortunate part. And while one can say that, oh, theek hai, Instagram pe itna time spend karke kya karna hai, but let's also realize that that also acts as restrictive as anything else. And therefore, the name the digital glass ceiling, because we realized a lot of these girls are not able to put themselves out there. They said, and our survey shows that none of them have a real profile online. All of them have fake profiles online. They don't put themselves out there, in the worry that just the way in this society, they're constantly being judged if they are seen talking to a boy, they are going to be, it's exactly the same online. If they are online, it is presumed they're talking to boys. If they are online, it is presumed they are doing something wrong. And trust me, the same questions with the group of boys revealed that there is zero checks done on their phone. Zero. There was not even one boy. There was one boy who said he shares the phone with his brother and therefore he was worried. Apart from that, there was no boy who said that his phone, there was any form of surveillance on his phone, and 100% of the girls said their phones were under surveillance by family members. So they could not go online and talk to that empathetic bot also if they wanted to. You know?
Just to add to that, I think because you're talking about, younger people or younger girls, for example, for even if we think of older women who are mothers, even for them, they don't have, there are many women who don't even have a personal smartphone. That the smartphone that is there in the house is the house's phone. So exactly what you were saying, that the privacy of is absolutely, it's a privilege, I feel, in today's day and age, and privacy is a privilege. If just taking on that, I feel in today's day and age, if you look at smartphones and all, I think we all would agree that iPhone, for example, Apple provides the best security and data safety of your data and all everything out there. But again, who all can afford an iPhone? And do we need to? I mean, is that the only way? So yeah, I think these are questions that we need to definitely start thinking about. And I feel for especially any woman who is going online, and any woman who is going online to share her opinion, and to share her opinion that is against the societal structure, is she's putting a lot of layers in her this thing journey of like making her even more vulnerable. And yeah, in our survey, what we did, we found out that the advocates we have become okay with dealing with rape threats and death threats. Like that has just become a part of our lives. We look at another rape threat, death threat, we move on. This is just going to happen. So I think that's how we're dealing with it. To be honest, like okay.
Yeah.
Like when you work on these government systems, how do you
Exactly.
incorporate gender?
Gender, yeah.
Exactly, I completely agree with both of you, and I really wanted to answer Sir also there because I am talking about marginalized communities and separate group of people, and we have to respect all of them. I know how to use chatbot, you know how to use chatbot, chat GPT, Gemini, whatnot, but women staying in a very small image under इतना लंबा पल्लू उनको नहीं आता है एंड उन्हें डर लगता है कि अगर किसी ने सिखा भी दिया हिंदी में भी यूज़ करके सिखा दिया देन व्हाट इफ़ किसी ने मेरा हिस्ट्री चेक कर लिया कि मैंने क्या क्या पूछा था चैट जीपीटी से इट विल बी सो एम्बैरेसिंग एंड मे बी वो शायद नॉर्मली अपने घर में कंफर्टेबली रह नहीं पाएंगी उसके बाद सो देर इज दिस स्टिग्मा देर इज दिस टैबू and we have to understand it. So there is this concept of middleman. So let me talk about there is this application that we created, me and my team all together, E-Swasthya Dham. So we went to E-Swasthya Dham is about Char Dham Yatra. So Char Dham Yatra, we tried to digitalize all the yatra by capturing pilgrims, tracking, tagging, monitoring, and all the vitals into one single platform so that we will be able to monitor and track the pilgrims going through the yatra. And if in case unko koi bhi difficulty aati hai, so there is a feature of pressing SOS and providing all the medical assistance to them. So ये पूरा application हमने create किया and then इसको implement करने के लिए हम लोग ground पे गए. So I was there in Uttarkashi with one of my colleague, Dr. Malvika, sitting right here. So we were there on the ground for good 15-20 days, and on the field we have seen बहुत सारे buses different parts of India से आ रहे हैं, pilgrims बहुत excited हैं और उनमें बहुत सारी women थीं different parts of India and communities. So when we were asking them कि मैम आपको बीपी तो नहीं है, मैम आप प्रेग्नेंट तो नहीं है, मैम क्योंकि क्वाइट एविडेंट था एक दो केसेस में कि लेडी वॉज प्रेग्नेंट 3 months 2 months, इट वॉज क्वाइट एविडेंट. वी आर मेडिकोज एंड वी नो, हमें समझ आ जाता था, बट शी वॉज लाइंग. Then I asked her, ki, why are you lying? Please tell me, we need to fill your whole data, it is for your good only. So she was so skeptical and scared ki, no ma'am, what if आप मुझे यात्रा पे नहीं जाने देंगे आगे? मुझे यहीं रोक लिया जाएगा. So I will lie. I have to lie. And महाराष्ट्र से कुछ लोग आ रहे हैं, मैं पूछ नहीं पा रही थी कि मैम आपको बीपी है, इससे पहले माला काइट्स नहीं है. काइट्स नहीं है माला. So I know Marathi because I have done my graduation from DY Patil Pune. So I was able to now the concept of local language as well. There is a high demand and need to know local language and people in the administration to know the local language so that you can provide all the comfort and understanding and trust within the pilgrims or patients or all the stakeholders wherever. So I communicated with her in Marathi कि ऐसा कुछ नहीं है, दिस इज़ फॉर योर गुड ओनली, आई एम हियर, प्लीज़ ट्रस्ट मी. मराठी में बात किया, तब उन्हें लगा कि अच्छा ये तो मेरे वाली है, इट्स ओके, आई कैन ट्रस्ट हर. उन्होंने पूरा डिटेल दिया, आई कैप्चर्ड इट, उनको उनका कार्ड दिया एंड उनका होपफुली जर्नी काफ़ी अच्छा रहा होगा. सो you know, these are some statistics and these are the most and main highlighted points that we need to understand. There should be empathy understanding and every underlying concept of related to human brain and mind to understand the need of being understood and being listened. So this is what we do when we curate any application and when we go for digital health intervention wherever. So this is how we do it. I mean, we are trying at
No,
least.
no. Thanks so much for that. Oh, yes, yes, yes.
Actually, not a question, but actually, maybe I want to augment the things that she was saying. So I think I feel privileged to say this that in that list of chatbots that was being shown, the first one was UNFPA Just Ask, and I have been very closely associated with that development from Dure Technologies where I work. So that ways, I think one thing that we do while making these chatbots is that we put up a lot of disclaimers and we give a lot of information there, but we, the privileged class, even, how many times do we read those disclaimers? We never do that. And there's a concept of anonymity that is kept in most of these developments, but that is not communicated across. So I think that the gap there is that psychosocial approach that we are supposed to take and make sure that the other person knows whatever I'm telling this system, the machine, or whatever, that is not being captured and nobody is retaining that information. It is just a translation that is being done there, and then a response is being just given to me for this transaction. And this is not associated with what is going to happen in the future. So many times we are developing technologies and we are keeping a hang of all of this. But I think we miss out on this, that the communication that is supposed to go is supposed to include that you're supposed to go through that disclaimer and we're supposed to translate that disclaimer to them. So yeah, just to add that.
There's a bunch of things I want
Yeah.
to say on that, which we found during our KII, which were very interesting, actually. So yes, none of us go through the privacy, whatever, details, and we never read them. But having said that, how many of those lines make sense anyway? It's not written for people. It's written by lawyers for lawyers, right? And which is the purpose of the research. If we really want people to be empowered, we need to start talking their language, just the way mutual funds did. And since fintech is what the health sector has been literally aping, we can see that. I think that's the next step. We need to start talking about these privacies in people's language so that people understand कि data क्या होता है और क्या misuse हो सकता है मेरे data का, which people don't understand as of now. The second thing is there are lots of apps that do capture data, especially femtech, right? The amount of data that they capture. No woman knows कि क्या हो रहा है उसका, right? So we need to really start questioning these things. The third thing is that a lot of people who work on creating these chatbots and everything, they all say we're GDPR compliant, we're DPDP compliant and all of that, and then लोगों को तो पता नहीं इसका मतलब क्या है. ठीक है, you're GDPR compliant, you're not storing data according to that compliance. During our KI, I can't name the people. We have had people from very, very reputed organizations telling us that they have shared data on WhatsApp because the government asked for it, because the donor asked for it. What's the point of that compliance? Right? And there was one person who said they had, and they realized while they said it that, oh shit, what did I do? Because they didn't even realize it. So that's what I'm saying. It's not out of malice. People are not doing this with a bad intention. We're doing this without knowing what we're doing. You know, it's entirely without knowledge. We are not used to privacy. This will not happen in Germany ever, right? It will not happen in Scandinavia. It will not happen. Because it's a different society. For us, we don't realize it. And that's the unfortunate part, and therefore that shift in narrative becomes so important. And while we're growing, it needs to happen then. There's no point in becoming like really very, very digital health compliant and then start telling people कि भाई अब तुम privacy के बारे में सोचो, अब read करना. We need to tell them now. You know, we need to tell them while they're putting in their data that this is important and it can, you know, I mean, it's very easy to say Digi Yatra safe है. क्या Digi Yatra safe है? मुझे नहीं पता. मुझे नहीं पता क्योंकि सब कुछ ही तो ब्रीच हो रहा है. So I don't know, right? And people need to know. It's their right to know. And
It is also about the level of sensitivity associated with data, because the moment I'm saying data privacy, or maybe I'm talking about cybersecurity, whatever. So I think
Everyone's super
there is
hungry.
an alarm that goes in everybody's head, right? We're talking about
He has a
something
question?
very serious, but not
Okay.
everything is that serious. No. Sometimes
Yeah.
I think we are just kind of bombing it up for them, and that is why they are too afraid to kind of use that. I mean, the uptake is way harmful. But I think we need to be sure that we talk about the level of sensitivity of everything that we are talking about, and I think that is a game changer. they would understand that, yeah, this is not that serious, or maybe I can share this information, and this is still okay. These are not the data sets which will kind of put me in a problem.
Yeah, I think there's a question. Yeah.
Yeah. So I've heard all of you, three of you, speak from your different perspectives. So I associate with an organization called ISDM, which is Indian School of Development Management. Fundamentally, our larger lens is, are there any skilling gaps in the social sector or in the development sector? That's our fundamental lens. So from that, I hear doctors speak about B2B and B2C. We understand that. And traditionally, we have seen right from the polio to the latest COVID, how the middlemen have played, starting with PFCs and ASHA workers in different forms and states in different states. So we all know how the middlemen have really solved as the last mile, and also from an NGO sector, we know if not NGOs in a country like India, India would have been continued to be backward 7,500 years back, right? So my essential question to all, and I also see that 30, 40 dipsticks, what you've done in and around Jaipur, and what is their understanding of digital and interpretation and stuff like that. So my basic question to all three of you is, do you think is there a skilling gap in the health sector which a SPO or an NGO can solve? When I say skilling gap, within the healthcare industry, we often talk about the paramedics, which plays a huge role, which includes nursing and things like that. Then we talk about the, the health workers, who's not really the paramedics. And we also talk about young India needs to go into rural and things like that. And anyway, India is getting younger at least for next 10 years or so, not after that. So a common question is, do you think is there a skilling gap which an NGO or a health worker who definitely needs to solve many of the last mile connectivity, communication challenges, and so on and so forth? Yeah, thanks.
That's a really nice question or statement. Thank you so much for that. So, according to me, yes, definitely there's a gap. And I really feel not only the normal common people, but there are health providers and healthcare professionals, I'm sorry. So, they are also hesitant and reluctant to use digital technology. As easily as they use Instagram, Twitter, etc., they are not able to use HMIS and EMR because they feel, oh God, lot of work, lot of typing, what to do. They simply practice writing prescription and giving it to the patient and work all around. So various healthcare providers, it includes policy makers or the administrators, doctors, etc., they also need to adapt the technology first. They have to educate them first, and then they will be able to educate the other people around. Also, in a setting of NGO and other things, we can definitely scale up the whole plan by, interning young youth, For example, in my team, there were recently, we got really good 3-4 interns who are Gen Zs, 20 years old, and we included them for our e-Swastham testing and e-Vedya testing. So they know the application, they know M1, M2, M3 compliances of ABDM and ABHA. So now they are the ones who will tell their whole batch while returning back to the college after completing their summer internship that, you know what, this is M1, M2, M3 is. We should also learn about ABDM and ABHA. So this is how education, awareness, and things are important, and we being NGOs or other stakeholders can do n number of things to scale up the whole lens and create all the impact going forward. This is what I think.
Yeah.
Thank you.
I'm not equipped to talk about whether the sector should be skilled. I'm not a part of it. But I think we're people who need to start giving our designs more important. Look at this podium. Look at this chair that I'm sitting on. The average height of women in India is 5'1". I'm 5'2". They're so uncomfortable. We don't make things for people. We don't communicate for people or to people. We communicate for ourselves. MTP. We keep talking about MTP. Where does a woman know what MTP means? Nobody knows what MTP means. We don't talk the language that people understand. We need to change that. If we want people to be empowered, we need to change that. If we don't want people to be empowered, we can continue showing off our knowledge. That's my point here. You see, that's where I think we can make a lot of things simpler. Middle people are absolutely important. There's no taking away from that, and there is no way our country will work without the middle people that you're talking about. But there are a lot of things that you can take off from their plate because they are overburdened. How much are we going to skill them? That poor Asha there has to do everything. You know, she has to distribute the napkin also, she has to take care of the pregnancies also, she has to take, if COVID happens, she's not going home also. What all will she do? And how will she be sensitive when she's so overworked? Right? I mean, it's a genuine question. It's impossible. And a lot of these things can be taken away if we agree to empower people by having communications that is talking to them in their language, which we don't do. Everything is like that disclaimer policy.
Just to add to that, I think even within the healthcare sector, I think the more initiative needs to come from the public healthcare system, because I feel that that is more designed to kind of in a welfare understanding. Because I mean, even as people working on abortion, we don't expect private doctors or who are actually working for profit to kind of engage with the sensitivity issues or whatever as much. They have a separate this thing, but who are working in the public healthcare, and it's not that it hasn't been done before, right? So what you're talking about, the MTP Act, absolutely people don't know about it. Similarly, there was the PCPNDT Act. PCPNDT Act was also people have no idea about, but then they did marketing for it through Beti Bachao, Beti Padhao. That again, the language of making it easier for people to understand, and immediately it got the message across, right? So it can be done, absolutely. And I think the language and making it accessible is the key.
Yeah.
It's very important.
And and this also leads to the last theme which I wanted to discuss with the panel, which is around convenience. I think you all have brought this point already. I don't have to get into the very details of how convenience is a really big factor in terms of dictating behaviors online. As we thought about these long huge policies, but nobody actually reviews and go through all of this, which we can see in our result also. If you look at the kind of responses we got for this particular question, if their health data is leaked, what they are going to do about it, right? So we see like there's a very small proportion which is passive in terms of this kind of a response, right? But there are people who want to take initiative, but they really don't know what to be done, right? So this essentially leads to the gap which we have been discussing in this in this whole period, right? There's a communication and design gap in terms of talking about data privacy, data governance, and especially which speaks to the young people. And that also is an opportunity for us, in terms of simplifying the language, create on existing platforms. We don't need new platforms anymore, right? And we should talk about what young people want and where young people are, rather than, replicating and creating new things to begin with. And importantly, addressing the digital gender divide, because gender is a component which is cross-cutting, right? And the design and, when we talk about healthcare in terms of speaking about person-centered care and everything, which has been highly endorsed within the healthcare space as well, right? But how much of it is actually built into the design of these new policies and frameworks, and it speaks to the audience in that sense. And I think this is a question for all the youth members, how might we communicate digital health in context of where we understand convenience will outplay privacy and the need of governance, who do not know about data governance, maybe you can think about it, about young people who are not really sure about, what these technical terms are, what this might look at, and it could be a good starting point for all of you to take this forward. Yeah. Any last few questions, and then we can wrap up. I guess you might all be very hungry.
Just one thing I think we can leave people to think about is that we are discussing health data and all. Now the next step is going to be Neuralink and neuro rights. Yeah. So what are going to be your neuro rights? That is something to go back and think about maybe. That's like the next step.